All right, well, welcome to this most recent episode of the Akkad and Coco Report. Today we're lucky enough to have Zeb Jamrozik here from Dr. Zeb Jamrozik here from Australia. He's a practicing internal medicine physician. He's a fellow in ethics and infectious disease at the Wellcome Center for Ethics and Humanities at the University of Oxford. He has a long list of accomplishments here. He's the head of the Monash WHO Collaborating Center for Bioethics of the Monash Bioethics Center. His academic work on infectious disease ethics is focused on vaccines, vector-borne disease, and drug resistance. So, Dr. Jamrozik, thank you so much for coming on.
Thanks for having me.
You've been, I've been following you for a while on Twitter. You've been a great follow because you kind of get to the heart of the matter, and your focus seems to be one that I particularly admire because it's very data-based and doesn't just kind of follow the consensus or follow the herd as a lot of folks do. So really been a pleasure to kind of follow you. So thanks for thanks for everything you've been doing. How are things in Australia at this point?
Look, things are pretty grim in Australia in many ways. As you've probably seen from the outside world, Australia has been trapped. It's effectively trapped itself. And the trap isn't so much the closed borders of Australia. The trap is zero COVID. The idea that we could totally suppress transmission of a respiratory virus forever when it was always going to become globally endemic. And that kind of commitment to that policy, which kind of many people agreed on, at least if it allowed us to vaccinate the whole population and then only have to deal with epidemic waves in a vaccinated population, which sounded like a good idea. That policy has kind of raised a number of challenges, not least the extreme costs of kind of border closures and shutting down society for extended periods of time. But also the difficulty in convincing people to get vaccinated when they can't perceive the risk of an infection that they've never seen. And just recently, we've started to have more cases and a more of a push for vaccination, but it's taken a very long time.
But so you've been pretty strongly, at least recently, been an advocate of this idea of what exactly you said, that look, this is something that is, it is going to become endemic. This idea of eradicating COVID is not something that's sensible. Now, Australia obviously took a very extreme path that was cheered on by many across the world who kind of favored this idea of eradicating COVID by shutting it down. When did you start to realize that this was, or did you realize from the very beginning that this was going to be impossible?
Yeah, from the very beginning. I mean, I came back from a meeting in London on human challenge studies and ethics in early February 2020. And it was already apparent then that this virus was completely out of control in many countries of the world. And that there was, even though it hadn't really been detected in large low-income countries or low and middle-income countries, it was inevitable that it was well established there in those countries, which often have a low average age, low disease severity of COVID on average, and poor public health surveillance. And I'm very much a global health thinker. And once a respiratory virus like this is established in very large low-income populations, which number billions of people on the planet, we're just never going to be able to eradicate it, unless by some miracle we got a vaccine that produced sterilizing immunity, which is, not a natural phenomenon for, at least most seasonal coronaviruses. And so any policy that was aimed at eradication, even by then, by February 2020, was futile. And by the time WHO announced the pandemic, it was even more obvious that it was futile. And I think some people in high-income countries were able to kind of put their blinkers on and think, well, we could eliminate it from our country. With all the resources that we have, we could plausibly eliminate it from our country. And I think, elimination temporarily from one country, that's possible, but it is incredibly costly. And not only costly in terms of health and finances, but in terms of kind of other important values of that society, if it's a liberal democracy. So rich countries could I could eliminate it from their country, but global eradication was never going to be possible unless we got a vaccine with sterilizing immunity, which, as you know, so far has not eventuated.
The idea that this was going to become endemic, did it clash with some of the models? I mean, there was a proliferation of models that were coming out early on that really drove what policy was, right, for the UK, for the US. I mean, there were these projections of, X million dead and healthcare utilization. So what were your thoughts when you saw that? I mean, was that were those reasonable forecasts? They were like, oh boy, I mean, this is something you can understand why folks were pushed to do what they did.
Well, I think we need to look at how kind of standard SEIR models have performed previously and what the predictions have been like previously. And, one of the unfortunate things in the kind of modeling community appears to be that in between emergencies, they seem to acknowledge that, gosh, these infectious diseases are kind of more complicated than the models can bear out. And, I wonder if we could add some more variables to the models and so on. But then, when COVID got going, just like in the 2009 influenza pandemic and so on, they produced these very simplistic models that produce apocalyptic estimates of what's going to happen. And sure, if we take those estimates for granted, you might think that we should take extreme action. But when you look at the fact that models have just about always overestimated kind of, hospital and ICU requirements for other respiratory viruses and so on, well, we need to think very carefully about the proportionality, and that's an ethical principle, the proportionality of the response to what the model is producing. And the other thing we need to think about is, well, are the kind of assumptions and the outputs, acknowledging that models are tautologies of their assumptions, are these biologically plausible? And if you see a model that has of a respiratory virus that has no attempt to account for seasonality and no attempt to account for, temporary immunity and reinfection, well, then that's not biologically plausible. And so one example of the problem with seasonality is that when the virus hit the northern hemisphere, it was in the middle of kind of the winter influenza transmission season, and there were these incredibly large large first waves in places like Italy and the UK and so on. Then modelers in Australia just produced models in Australia when we were in the middle of summer, estimating that the same thing would happen. And of course, the same thing didn't happen. The first wave we had in Australia occurred at the lowest transmission period of the year for respiratory viruses, and it was much easier to get on top of. And that gave people this kind of false confidence that what we were doing in Australia was working really well, when in fact, summer was lending a very big hand. And the models just didn't include seasonality at all. It didn't account for that at all.
Yeah, so you brought up in a nice paper in the History and Philosophy of the Life Sciences about how historically, what historical epidemiology is, how that should play a role in this. And this is bringing up, that would have brought in all these things, right? That respiratory viruses have a seasonality associated to it and whatnot. And these simple SCIR models with one big massive peak that, results in megadeath wouldn't work. Why were those? I mean, why were those ignored? It's a brilliant paper. We'll link to it in the show notes. It nicely provides context, but there's clearly a disconnect between folks like you and who are writing about this. That seems to make a lot of practical common sense, and then the folks that are making policy. Why is there this massive gap?
Well, I mean, that's a very big, complicated question. But my colleague who first authored that paper, Dr. George Herriot, he's an infectious diseases physician, is very knowledgeable about infectious diseases. He also has a PhD in modeling of a certain type and kind of understands the mathematics involved. But we were both struck very early in the pandemic where we were like, well, there is some good news here. When we first read the data coming out about COVID from China in February, one piece of good news is that it's a coronavirus. And, one thing we know about coronaviruses is they're not very dangerous to young, healthy people. Even SARS or MERS, which are kind of, the worst case scenarios for coronaviruses, have a very clear age gradient in severity. That's one thing. And the second thing, what was already obvious, is that it wasn't SARS. It was nowhere near as fatal as SARS, even based on the early Chinese data biased by ascertainment and underestimation of the asymptomatic fraction and so on. So there were some very reassuring features at the start. And the other thing that George Heriot and I were interested in here was, well, what's happened over history? And one of the things we did, we went and got a book on data on every influenza pandemic going back to the 18th century. And if you just look at what happens, every single time, there's seasonal waves of infection, and gradually herd immunity is established, but not the kind of herd immunity that most people think the word herd immunity means. And I listened to your other episode of this podcast on herd immunity, and it has many meanings, but many people interpret the word herd immunity to mean that what's going to happen is that everyone becomes immune and they can't be reinfected, and then transmission will eventually drop to zero and we can eliminate or eradicate the virus. But that's not the only way herd immunity works. The way it works with respiratory viruses, for the most part, including influenza and every other coronavirus that's become endemic, is that we end up in an endemic equilibrium where there's infections, people being reinfected every year, immunity dropping off, reaccumulating, seasonal waves, and settling down into this kind of stable pattern. And that happens over a few years after kind of a large pandemic. For example, H1N1 influenza, there were a couple of big initial waves, but people still, every year, I admit people to hospital with H1N1 influenza, and it's the same virus that was there in 2019, and we're just in this nice stable equilibrium. So it's obvious that that happened all the time. And the other interesting thing, of course, to ask is, well, many people said, oh, we can't make assumptions based on what we know about influenza to tell us about what's going to happen with this coronavirus. And I think a big problem there is that many people in the public health, epidemiology community hadn't even heard of coronaviruses or seasonal coronaviruses. People in the media hadn't heard of it. And the way you know that people in the media hadn't heard of them is that they were writing the word coronavirus with a capital C. And that shows you that they think that there's a brand new phenomenon, but it wasn't brand new at all. And we do know a lot about seasonal coronaviruses that could have been useful to tell us about what was going to happen here. And so the idea that we started with a blank slate of knowledge and that we could only build up science from zero is completely absurd. But just to focus on the kind of past pandemics thing, look at what happened previously. And the other interesting question we wanted to ask was, well, could some of these previous pandemics that were labeled as influenza actually have been other respiratory viruses? They could have been new coronaviruses, potentially they could have been whatever, new variants of RSV or something. And there was some tantalizing evidence of this. Some PhD student had previously done their work on the OC43 coronavirus that had largely been ignored up until 2020, where they had estimated, based on molecular analyses, that maybe this virus emerged around the time of 1890, which was when there was a large pandemic known as the, quote, Russian influenza pandemic. And when you look at historical accounts of that pandemic, gosh, they really look very similar to, COVID-19 in lots of ways. And so that was one of the things that drove George and I to write that paper, just to look at pandemics in general, but also to look at the possibility that, some of these previous pandemics might have been caused by coronaviruses at a time when it was impossible to distinguish COVID, different types of COVIDs from influenza.
So is there anything we could do better in 2020 that the 19th, 18th century populations could not? Like what would, you're running point on this in February of 2020, and the Australian Prime Minister says that you tell me what to do and I'll do it. What would you do, and how would you frame it? How would you frame that to the population? I know it's kind of an unfair question, but
obviously it's a big question, and there's a lot of things we could do better. And it's not always about kind of deploying more technology or more interventions. I think one of the most important things for me as an ethicist is that whenever public health people want to use fear to motivate people and to motivate them to change behavior, they need to think twice. they need to think very carefully. And one of the most compelling things I've ever read about pandemic planning was in a paper I linked recently, which was to say that, you know, human communities respond best to an emergency like a pandemic if we can avoid an excess of fear and panic, and if we can try and keep society functioning as normal as possible. And once we allow fear to take over in the minds of regular people, but also policymakers, we end up with very disproportionate interventions, and we end up with, you know, backlash, side effects, and unexpected harms of our policy that have promoted fear-based accounts of a new virus. And it's clear that, you know, that's something that really took hold in 2020 and has caused all kinds of problems. And the second thing, you know, that I would say, but that, you know, governments don't always want to hear, is that a key way we should be managing public health responses to emergencies is focusing on transparency. We should be as honest as possible with the population about all the data that we have to hand and about the way decisions are going to be made in policy and how we're going to take different things into account. And again, I think, you know, governments succeeded in a greater or lesser degree of doing that. But you know, I would think those would be two big picture things, not to promote fear and panic, and to try and, you know, defend liberal democracy by promoting transparency.
Now, you know, the ethical part of this is really, really, really interesting. And that's a great discussion about how far to go. And Australia's, you're going to tell us a little bit about how far Australia has gone with that. But can you realistically see in February or March, with a pandemic raging, where, you know, there is definitely going to be excess mortality? There's no, if it gets into a population in a significant way, there is going to be excess mortality, no question about it, with that age gradient. Can you see anyone, especially when you're in an island like Australia is, how do you say we're going to keep flights coming in from China or Italy or whatever, from anywhere? How do you how does one do that? Because what you're saying, and what seems to make sense to me now, is that, and I wasn't in this camp, you know, when I was sitting here in March in Philadelphia and the New York epidemic was raging, you know, I was raging about, you know, people being allowed to leave New York. I was like, my God, keep everyone in New York. Why are we letting people leave New York? You know, there was all sorts of fights between governors of states. One governor was trying to get the police out to stop them. The New York governor was saying, no, I'll sue you if you stop New York people leaving. So, you know, it was a time of conflict as people were trying to scramble to do what they wanted to do. But now looking back, it seems silly. It's like, okay, so what was the point in trying to quarantine New York when, you know, it would have come in from Mexico or Florida or Delaware or all these, you know, it's impossible. But are you saying that in February, March, when you say keep things going as much as possible, does that include keep travel going? You know, what do we do? Or do you keep travel going, and do you somehow try to put nursing home or senior citizens in some type of bubble? Like, how would you mitigate that excess mortality? That excess mortality is going to exist if you don't do something drastic. How would you do that?
I mean, that can be a difficult sell, of course, but I mean, I think the first thing would have been to go back and look at recent previous pandemics, and even things that haven't been labeled as a pandemic. So, for example, the 2017-18 influenza B waves, which went all around the world and really probably was a pandemic. I was on duty in hospitals in Australia in 2017, and it was a catastrophe. There were just so many people coming in with influenza of all ages. Many older people were dying. You know, children were being admitted with severe influenza. Hospitals were full. I would come down to the emergency department every morning, and there would just be patients lined up with influenza, and it was the dominant cause of admissions. And if you look at, say, my country, we're keeping very good excess mortality data every year. And if you go back and look at the Australian Bureau of Statistics data for 2017, there's an immense winter peak of deaths in that year. And from memory, it was kind of about 300 excess deaths per week. And so we need to put this in the context of what happens in bad winter seasons in general. And say to people, you know, but it is a hard sell to say to people, there is going to be some excess mortality from this, quote, new virus. But we need to point out that, there's excess mortality from other types of viruses in winter every winter, and that much of that mortality is concentrated in nursing homes and aged care facilities every year. And to prevent that, we need to institute radical change. And you might think we don't do enough for infection control in nursing homes just in regular years to prevent that excess mortality. If you think protecting those people matter, then we should be doing more of it in regular winters. But to go to the part of your question about should we keep international travel going? Well, previous experience with influenza suggested that international travel bans weren't that effective, because by the time they were instituted, the disease was already well established and there's large asymptomatic fraction and so on. I think it's fair to say that for isolated countries like Australia and New Zealand, travel bans did work maybe better than people expected for COVID-19. But the problem is they come with immense costs, and not just financial costs from reducing economic activity, but the costs that your citizens can't freely come and go, that citizens who are overseas can't return home. In Australia's case, that citizens have been banned from leaving their own country and prevented from moving around their own country, like you said happened between the different states in the US. And the other thing is, what you said is, if we don't do something drastic, something bad will happen. That was kind of a narrative that many people found appealing at the time. But we need to consider the flip side of that, which is, if we do something drastic, something bad will happen. And right now in Australia, for 14 out of the last 20 months, we've been running at excess mortality. And that excess mortality is from cancer, diabetes, dementia, and that's a result of the drastic things that we've done. So sure, some lives have been saved from COVID, but many lives have been lost because we were so drastic in our response. And we need leaders to stand up and say, the country is the whole population in the country. And everyone in that population has interests, and everyone in that population, we need to try and defend their health in a fair kind of way. But if we go really extreme to try and protect kind of largely much older, much more frail individuals, well, that's going to have immense costs for everyone. And we need to have a public discussion about what those costs might be.
Yeah, I mean, I think you have these statistics from the Australian Bureau of Statistics, and again, this is playing the utilitarian game of, well, we do these drastic things and we reduce net mortality, and therefore it's worth it, which has its own set of problems that I'm going to let Michelle opine on. But according to the Australian Bureau of Statistics, death in Australia has increased 5.6% over the pre-pandemic seasonally adjusted average. There was a concern that shutting down hospitals to flatten the curve would kill people. The elite, knew better, right? That this one, that it would all be okay. But again, as you brought up, according to the Australian Bureau of Statistics, cancer deaths are up by 8.9%. You destroyed small businesses and other businesses to protect the elderly in nursing homes, but yet dementia deaths are up almost 20% in Australia. Deaths from respiratory diseases are up 1.9%. I mean, the list of these things goes on and on. Is this well known to the Australian public, and is there a understanding that no?
There's almost no media discussion of the fact that we're running at above average excess mortality, and that there's starting to be a little bit of discussion about how, for example, we've got massive increases in mental health harms. I mean, that's happened all around the world, of course, but yeah, pediatric mental health admissions are up over 100%. Eating disorder admissions are up over 100%, and eating disorders have a very high mortality. Lifelong.
But see, Zeb, it's okay. The kids are resilient. At least they'll survive. That's what we hear. The other aspect, that was a complete sarcasm. The other aspect that you brought up in a wonderful thread that we'll also link to is the infectious disease aspect of these severe risk mitigation measures. Correct? And I mean, I learned about I learned from your feed about this massive RSV outbreak that seems somewhat global and worldwide. Can you talk a little bit about that? Why, this RSV normally hits, as most doctors know, hits in, as most parents know, hits in the fall, winter, etc. And suddenly you had these massive outbreaks happening around the world when things were warm in the summertime. So can you talk a little bit about the scope of that RSV outbreak globally, and your thoughts as an ID doc as to why that's happening?
Yeah, and just to be clear, I'm an internal medicine doctor, but I'm not trained in infectious diseases. But I have an interest in that in my research. But I mean, this is kind of partly linked to the thing you asked earlier about border closures, and it's something that maybe wasn't as easy to predict. One thing we didn't know is how well measures for COVID-19 would work in suppressing other infectious diseases, such as influenza, RSV, enterovirus, norovirus, and so on, even some bacterial infections. We didn't know how well it would work, but kind of halfway through 2020, it was already extremely obvious that they'd all been suppressed. And some very short-sighted people, many people, including in the infectious diseases community, celebrated that. They were like, great, we've managed to suppress all these other diseases. Look at all these other lives we've saved from these infectious diseases that haven't occurred, just as a side effect, a so-called beneficial side effect of COVID-19 policies. But if you just stop for a moment at that point and ask yourself, given that these viruses are not going to be eradicated worldwide, what's going to happen when they come back? And there's been this idea proposed of immunity debt. And the reason it's kind of labeled like that is these viruses most of the time are held in check by a balance between herd immunity across the populations of those viruses and the incidence and mutation into new strains or variants of those viruses that's happening every year. And so the amount of, for example, RSV, which, as you mentioned, is a dangerous respiratory virus, which is particularly harmful to infants and young children, but also kills many older adults in nursing homes every year, many of my patients in adult medicine. The amount of RSV that occurs every winter is determined by, how much immunity there is in the population, how different the latest variant of RSV that's circulating in the population is to the other variants that we have pre-existing immunity to, and what kind of winter it is, the seasonal factors that are at play. But if we take away RSV for a whole year or for 2 years, then there's going to be much less. First of all, there's going to be much less immunity to RSV in general across the whole population. Second of all, there's going to be a lot of young children who've never had RSV, which almost never happens. I mean, most 95% or more of children by the age of 2 have had RSV. And thirdly, we add a kind of chaotic factor, which is which variant of RSV is going to be reintroduced into the population when international travel resumes. And if it happens to be a variant that's relatively well matched to local herd immunity, well, then it might not be too much of a catastrophe. But if there's a major mismatch and the herd immunity has gone down, then you can have very large outbreaks. And we've seen this all across the world, from New Zealand to the UK to the United States to Australia. And it's been very carefully documented here. And once we knew that these other viruses were being suppressed by measures for COVID-19, it was totally predictable that these rebound epidemics would occur. But this is something that, we've never seen before. And, a realization that I've come to across the course of the pandemic is that the fact that countries around the globe are connected by international travel means that there's kind of a global herd immunity to these viruses that's shared across the global population. And once you start cutting yourself off from other populations, well, then the viruses are evolving separately in different populations. And each of us is becoming kind of like the Americas before they were colonized, where they're cut off from kind of major population centers around the world. And the longer we remain cut off, the further away we drift. And then as those populations come back into contact, where it's the perfect conditions for kind of large rebound epidemics. And that's what we're seeing everywhere in the world right now.
Yeah, so, that's beautifully said. And it speaks to why it's very short-sighted to perhaps cut off travel, because you may want virus is circulating in a young, healthy population, if you can manage that. um, uh, what do you, so, in the, I don't know what's going on in Australia with kids. I mean, you guys are still in lockdown mode, I guess. So you're still suppressing. Are you still highly suppressed all across the board?
So things have come apart in Australia in recent weeks. In our two largest cities, Sydney and Melbourne, we've started to have what we think of here as kind of decent sized outbreaks, which is kind of like 500 to 1,500 cases of COVID per day in a population of around 5 to 8 million per city. And vaccination has dramatically increased. And yeah, those large cities are in lockdown. Some of the more isolated, smaller cities in Australia haven't had a lot of lockdown overall, and have been living relatively normal but highly isolated lives, unable to travel within their own country to other states and so on. And yeah, the schools thing, I mean, school closures are a catastrophe, and prolonged school closures are an ethical travesty of the COVID-19 response. And if you look at pandemic planning documents, written when everyone was sober and calm, and experts sat down and said, what would we do if there was a really bad pandemic? There was consensus that, as people say now, schools should be the last to close and the first to open. But what that meant was that schools should be normally closed for no more than about 4 weeks, and definitely no more than a few months, and only at the peak transmission of a wave. That's the only time it would be justifiable, people thought, when they were writing pandemic plans, to close schools. And in many places around the world, as you know, schools have now been closed effectively for over a year. And I mean, this is obviously a catastrophe for children's mental health. On average, for children's education, it has very unfair and unjust effects on the least well-off in society. That's the children in poor communities who need access to school the most, for all kinds of reasons, who are going to suffer the most from educational losses. And apart from the kind of mental health harms, it's also going to lead to infectious disease harms, because schools, or at least mixing of children, whether that happens at school or not, yeah, that is a site where infectious diseases are transmitted at a time when, just because of the way human biology is, the average risk of those infections is in general lower than at other times in life. In children aged kind of 5 to 10. And if we've taken them out of contact with each other for a year or 2 years, again, we're going to have rebound epidemics. It's inevitable. We're creating the conditions for that.
It sounds like Australia is setting itself up for some pretty significant rebound epidemics when both the folks within Australia start circulating, and certainly whenever your dictator, prime minister, allows travel to restart. Michelle, what do you think?
Somebody needs to be the devil's advocate here. Let me be the devil's advocate. Zeb, I'm trying to understand what does ethics, or what can an ethicist contribute to public health policy here, without this being sort of a clash of preferences. I mean, on the one hand, you can say, listen, it's going to be really bad if we do these major lockdowns for a long time, or a zero COVID policy. We're going to have, mental health being affected, the children, those school closures, these rebound epidemics of these other respiratory viruses and so forth, on and on. And then somebody could say, well, I mean, we could, but maybe, the alternative would be worse. I mean, that's the opinion of the guys who impose the lockdowns. They say, no, we think that the alternative would be worse. We think that if, maybe, precisely, it's because we have made those major lockdowns that we didn't see the apocalyptic predictions come to fruition. Is it just a matter of somebody's someone's view of common sense versus another person's view of what is commonsensical, or how do we sort this out?
Yeah, so I guess there's a couple of different questions there, but one is, what's the role of ethics? And yes, I mean, my work is all in infectious disease ethics, and public health ethics is a growing field of bioethics. And there's a whole lot of principles in public health ethics that are supposed to be used to justify public health intervention, like proportionality, equity and fairness, reciprocity, transparency, and employing the least harmful policies and so on. But one of the things ethics is good for here, I think, or could be good in public health if people were more aware of its role, would be for identifying the kind of values that are at stake. That it's not just about the kind of numbers produced by models or so on. It's about what values are at stake. And, basically those values are kind of like well-being, fairness, and freedom. I mean, those are the kind of three key values in public health. And also about identifying not only what the kind of aggregate effect of public health benefit and harm is expected to be for a given set of interventions, but what the distribution of those benefits and harms is going to be. And that's a key question for justice, which is an ethical principle. So if a set of interventions is going to mainly save the lives of people over the age of 80, and if the harms are going to accumulate predominantly to children, young healthy people, parents of young families, especially women and so on, well, we can ask questions about whether that's a fair distribution of benefits and harms that we can expect from the policy. So ethics can help us identify, what's at stake, how to weigh those values, and what the significance of the distribution of those kind of benefits and harms is. But ultimately, as you say, there's not kind of one right answer here. And, in democratic countries, it's supposed to be a matter of public debate, transparent public debate, where we can put, what we think the best estimate of the situation is and the likely outcome of intervention might be. And we need to have a public debate about what the appropriate way to proceed is that's kind of as rational and deliberative as possible and not characterized by fear. But I think one of the key things here is that we shouldn't be too black and white about it. That there's an alternative. The only alternatives are lockdown or, quote, let it rip, or like laissez-faire. A key thing for public health ethics is that each public health intervention, and lockdowns made up of many, many, many interventions, each public health intervention should be weighed on its own merits about what benefits and harms it's going to produce, what the balance of benefits and harms is going to be, and how they're going to be distributed in the population. And so it's kind of a false dichotomy to present people with either the apocalyptic predictions of infectious disease models or shutting down the whole of society, because we could choose to shut down more or less of society, or for a greater or lesser period, or we could choose to leave schools open as a priority, just as one example. That it's not the case that we have to do everything at once, and that the justification of that package, ethically speaking, justifies every single kind of part of that. That's not true at all. And one of the problems is not only do we not have any evidence that half of this stuff works, or what the effect size is, or what the benefits and harms attached to it would be for each one of the policies in kind of lockdowns, but in many cases, people haven't even bothered to try and collect those data. There's very clearly a role for kind of cluster randomized trials looking at, well, what would happen if we close schools in one area and not in another area, and what would the outcomes be? But there's often not a lot of real data to guide us.
So I mean, do you propose that essentially these things be adjudicated? That, I mean, immediately we should have a bunch of randomized, cluster randomized trials everywhere, and just make it. But I mean, what is because the principles that you list, I'm trying to. I'm not playing devil's advocate. I'm actually putting ethics on trial, because we have the same thing in medicine. You have all these principles, justice. In medicine you have justice, autonomy, and I forgot what the others are. They conflict with one another, right? They are frequently in conflict with one another. So not only do you have the task of identifying for each principle, where do you fall, then you have the task of, even if you determine the distribution, like for fairness, the distribution, who's going to bear the cost, then what is fair or what is not fair? You have this one distribution versus another distribution. I mean, you can argue about whether this one is more fair than another. And then you have the task of putting them all together and deciding, how you're going to come out and make. So, I mean, it seems like a lot of, at the end of the day, whoever's in charge is going to, have to make a decision. It's going to be might is right. Furthermore, I don't know, 70%, 80% of the Australians are delighted with their lockdown policies, or I mean, isn't that the case? Or I mean, I maybe I'm confusing Australia with New Zealand, but I think in general, people have been, pretty, I mean, hasn't been much discontent. So if in a democracy, we let the public, the greater number, if you're going to have a public debate, it's likely that everybody will say, no, let's do the lockdowns. It's I'm in support of your view, actually. What you consider your common sense view, I share it. I'm just a little bit skeptical about principles of ethics as they're currently understood to help move the conversation in the way that will, give your common sense assessment a bigger voice.
Yeah. Well, I guess one of the key things is what failed to happen at the start of 2020 was that we failed to have an informed debate. And if you look at all the kind of policy documents and modeling outputs and the kind of Ferguson group in the UK and so on, fundamentally, what they asked infectious disease modelers to do was to estimate, well, if we had some really drastic intervention that would reduce the incidence or spread of this respiratory virus, how much would cases go down and how much would deaths go down overall? And so the only thing they really asked them to estimate were the benefits. And there was no real talk or no serious effort put into estimating what would the harms be. And until we have some estimate of the harms, you can't even make an informed decision about what to do. So that's one thing where ethics could help, saying, well, sure, there are benefits of this policy. I mean, I agree, plausibly there are benefits, but also there's significant harms. And until we know about that, well, we can't make a decision about what to do. Also to be clear about that, not every death is equal. If we prevent deaths in people who are in the last 1 or 2 years of their life, most people, if you sit down with them and get them to reflect, will agree that dying early when you're 85 and you're expected to live to 87 is not the same as dying early when you're 25 or 15 or 5 years old. And that there's obviously a lot of room for different opinions about how much weight we should give to the protection of interests of young people. But almost everyone in almost every society in the world agrees that we should give some additional weight to protecting young people.
Except that the young people don't vote, so politicians disagree. They give much greater weight to the elderly who who are typically the bigger voters. I mean, that's I hear you, but on that question of I don't know. I mean, did you have anything else to say? Because I want to segue into your particular research, but I think there's a connection here between the particular research that you do with human challenges in terms of how you can experiment in order to get the data that you want during pandemics, and whether it's the correct ethical, I mean, it's going to help ethics, so to speak, move forward. So tell us a little bit about these the papers or the core of your research. I think it's the core of your research about what's called human challenge studies, or?
That's right. So yeah, human infection challenge studies are a type of research that involves the intentional infection of volunteers as a way of learning about infectious diseases, immunity to those diseases, and in many cases, investigating vaccines. And I first heard of them being, I've spent a lot of time working on this area.
So just to be clear, you were working on this prior to COVID, before COVID was even a thing. Okay.
Yeah, that's right. So I spent a lot of time working on the ethics of human challenge studies. I've written a book about it. I've covered kind of 300 years of history of this type of research. And in particular, I was in that project, we were looking for kind of the conditions under which it would be ethically acceptable to do this type of research, or more or less ethically acceptable, and so on. And they've been done for a whole range of diseases. People might not be aware, but they've been done for malaria and yellow fever, 100 years ago. Classically, they were done for smallpox at the time of the kind of smallpox vaccine development. Then more recently, they've been done for common cold coronaviruses at the UK Common Cold Unit, which was tragically shut down in 1990. Otherwise, we might know a lot more about common cold coronaviruses than we do now. They've been done many times for influenza. They're starting to be done for many parasitic, neglected tropical diseases and so on. And they can be an immensely powerful type of research, scientifically speaking, because they allow scientists to monitor the infection from the moment it begins, to make detailed measurements of the immune response and the trajectory of the infection, and to get very early readouts on whether a vaccine is providing protection and what kind of protection, and importantly, how much protection against asymptomatic infection. Mm-hmm. And they can also be used to study transmission. So they've been used in the UK and the US to study how respiratory viruses are transmitted, to look into, for example, is touching your nose an important factor in the spread of viruses? How often do people infect each other in the same room, and so on? They could be used to investigate masks and how well they work in different contexts. So they're a really interesting type of research, but obviously, ethically speaking, when we are intentionally exposing people to infection, it's a very sensitive type of research. And many people say, how could it possibly be ethical? Many people point to kind of, tragic, unethical cases that occurred during World War II, which were not done with people's consent and featured in the Nuremberg trials and so on. But, one answer to the question of how can they be done ethically is, well, the benefits of the research have to outweigh the risks to the volunteers, and the risks to the volunteers have to be minimized. And importantly, the volunteers have to provide, very careful, informed consent before they participate. So a key question all the time is going to be risks. How risky is it going to be to volunteers? And typically those volunteers are young, healthy adults, kind of for obvious reasons. They're usually the lowest risk, and they're, unlike children, able to provide informed consent easily. And so, moving to COVID, I just finished this book on it in 2019-20. And then the first time I heard about the idea for COVID was in February 2020. People started to say, we might want to use human challenge studies for COVID-19. And like I said, I just got back from a meeting on this topic in London at the time. And, reading out the data that came out of China very early, it seemed pretty obvious that it plausibly could be, a candidate for an ethical challenge study to use COVID-19. Why? Because the risks in young, healthy adults are not very high. And because, the public health harms of the virus are significant. And if we could use challenge studies to better understand the virus, asymptomatic infection, symptomatic infection, immunity, and test, vaccines, when we've got so many vaccines to test, well, that could help considerably. I served on and first authored some World Health Organization policy on the ethics of COVID-19 challenge studies, and was involved in kind of various debates on this topic. And as you might be aware, that research has finally gone ahead. So 2 research groups in the United Kingdom have started doing challenge studies with COVID-19 in young healthy adults. One study in people without previous immunity, and one study in people who've previously been infected, looking at reinfection, which is like a really important question right now. But obviously there was a lot of pushback. Many people thought it's a dangerous new pandemic virus. The risks or the uncertainties are too high. It couldn't possibly be ethical and so on. But
the bottom line is there anything different about this kind of experimental study as opposed to a drug study or an experimental drug study or a surgical,
yes, excellent.
A new surgical surgery?
Excellent question. I mean, with respect to the risks, there isn't really, as you're probably alluding to, phase 1 drug trials have sometimes produced severe harmful outcomes. Mm-hmm. And probably at least some types of phase 1 drug studies probably have higher risks than human challenge studies, like first in human phase 1 drug trials, which, as you know, have led to death, ICU admission, amputations, and so on. Human challenge studies don't have those kinds of outcomes because they're very carefully designed, and because we actually know quite a bit about the pathogen before we're giving it to people. So the absolute risks are probably no higher than phase 1 drug trials and might be lower. But I think what's different is the way people respond to it. And partly it's people's emotional response to infection, where it kind of raises these deep human feelings of disgust, the idea that you're going to be infected with a pathogen And culturally, that must go back kind of millennia, that response people have. And also because we've had these unethical examples in the history of research involving infection, people respond, very emotionally to it. But if we sit down and look at the kind of the risks, they might not actually be, unacceptable.
That's very interesting. And where do you fall on the question of compensation of human subjects, or how should they be compensated or not? Or I know that the consensus in general is that they shouldn't be compensated, or at least only very modestly, so as not to be too strong of an incentive.
Yeah, that's right. The consensus in ethics typically has been that large financial payments could create undue inducements for people to participate in research. And the worry there is that they might participate in research they wouldn't otherwise do if they weren't being paid, or they might hide important information about, say, their health status that might make the research more risky or might undermine their participation in the research in terms of the scientific outputs. And sometimes people also worry that payment for research participation can generate a kind of research underclass where only the poor people in society end up participating in research, and they do it for money because they have no other options. And that's kind of more a problem with the society, I think, rather than with the payment per se. But look, most people think that at least some payment is justifiable, and that one way of thinking about this, ethically speaking, is that the payment should track not the risk so much, but the inconvenience. So how much time do you have to spend participating in the research? And in human challenge studies, often people have to stay on site, in a quarantine station for 2 weeks or 3 weeks. And I think in that situation, many, if not all, and certainly the ethicists who worked on this specifically, agree that potentially what might be perceived as large payments of, say, $5,000 or something might actually be reasonable compensation for that degree of inconvenience, that amount of time taken out of your life and so on.
Right. No, very interesting. Very interesting. I would imagine, I don't know if do ethicists think that human challenge studies with infectious diseases at least give you the benefit that if you survive, you have developed immunity, which you wouldn't otherwise? Is that factored in?
Well, so I personally was really strongly in favor of that idea for COVID and just in general, that immunity is a benefit. Now, some ethicists I spoke to about that were uncomfortable about the idea that we would consider it a benefit, partly because you have to undergo some small risk to get that benefit. But when I was first talking about these challenge studies in March 2020, I was speaking to young doctors at my hospital before a big wave of COVID hit Australia. And I said, would you people under 30, young and healthy, would you participate in these studies? And I asked about 50 people, and all of them said yes. Right. And many of them said the reason they would participate is it would give them immunity against the next time they were exposed to COVID-19. And one of the real unscientific narratives that came out during this pandemic is this doubt about natural immunity, that there wouldn't be post-infection immunity to COVID-19, which is just ridiculous. Of course, there's post-infection immunity, even if reinfections do occur, they're less severe and so on. And so I personally think, I would have been willing to participate in one of these studies. And part of the reason I would have been willing, apart from altruism and scientific interest or whatever, would have been to get immunity in a way that's controlled, right. Safe, monitored, and so on.
Yeah, no, definitely. But there seems to be, again, kind of a strong bias against doing this as opposed to developing a vaccine. I mean, there's a pro-vaccine. Again, I have nothing against the vaccine. I have a few things against the vaccine, but in general, I'm in favor. I've been vaccinated myself. But from the get-go, it seems to be sort of where most of the emphasis is placed, that the only kind of immunity that one is allowed to get is the one that you get from a vaccine. And
basic immunology and everything I was taught in medical school and experience of people who have been exposed to infectious diseases tells me that in most cases, not all, but in most cases, immunity from infection is better than immunity from vaccination, which is not to say that immunity from vaccination is kind of bad or unsatisfactory. It's often very good. But if you take whatever measles or varicella zoster, the virus that causes chickenpox, in that one in particular, it's quite clear, for example, that post-infection immunity is better. Now, it leaves you with the risk of shingles, but it's better than vaccine-derived immunity. And that's what we would expect. I mean, that's how the immune system is created, and most vaccines aren't producing kind of, a full range of antigens to the immune system and so on. And so, yeah, I think there has been a bias towards vaccine-derived immunity, and partly it has been because public health authorities kind of don't want people to know that you would get immunity after infection, because they're worried that it would encourage people to get infected or to perceive themselves as kind of invulnerable after they had been infected or something. But I just think we need to be honest with people, and distorting the science to fit the public health narrative is a problem, because people will lose trust in science and public health when they find out that they've been deceived.
Right.
And so it's important that we just tell the truth and,
right.
treat people as thoughtful, intelligent individuals.
Great. I have one last, I don't know, unless Anish, you have something else to add. I have maybe one last question or comment, or ask you to comment about. So medicine, we had an ethicist, I think maybe 2 years ago, a very fascinating guy, Tom Koch, who's a bioethicist, but he decried a little bit the way ethics had been sort of made a separate discipline from medicine, or moved away right in the 60s. You had big scandals. Medicine had abused a lot of its status as a profession and whatnot. And then bioethics came to be. And now you have bioethics as sort of an independent, profession or field or whatnot. And then they tell doctors are essentially technicians, and the bioethicists give us the parameters of what's acceptable for us to do or not to do. And I think there are problems with this thing. On the other hand, in public health, I mean, has a day of reckoning come to the public health community? You alluded to that there's now more public health ethics, but has there been, or is there a need for a crisis in public health to come about for people to say, listen, we need public bioethicists or something of that sort, or should public health intrinsically, I think in medicine, should be intrinsically an ethical endeavor, and the problem with it is that it's moved away from that, and it's become sort of a primarily a technical endeavor. And I don't know if how you view the future of the relationship between public health and ethics.
Yeah, great. So on the first part of your question, I agree. Medicine is fundamentally an ethical endeavor. We're always, as clinicians, weighing benefits and risks and helping our patients to weigh benefits and risks. And almost every clinical decision is partly guided by evidence and partly guided by ethical values, and people are often doing that unconsciously. And so, there's this problem of kind of academic siloing, where often these kind of areas, both the ethicists need to be educated in clinical stuff and evidence-based medicine, and the clinicians need to be educated in ethics, and there needs to be much more kind of interlinking. That's a problem in academia in general. And then the same thing's true of public health. We need to be training the public health people in ethics and training the public health ethicists in, evidence and epidemiology, because otherwise they kind of in parallel need to be talking to each other. But this pandemic has revealed that there's two huge crises in public health. There's a crisis of evidence, where many public health interventions are being done without evidence and without even the desire to collect evidence. So there's a crisis of evidence-based public health. And part of that has been because of kind of, a perception that it would be unethical to do a trial of public health interventions, or that it would be impossible. But as adaptive trial designs and cluster randomized trials and so on have shown, it is possible to do this type of research. And I don't think it's not only that it's not unethical, it's extremely ethical. In fact, it's ethically required that we collect those kind of data to make sure that we're doing the right thing, just like in clinical medicine. But public health, I don't think, has come around to that. And the second crisis in public health is an ethical crisis. Many public health actors, if you ask them previously, during the HIV pandemic, was it, all things considered, in retrospect, a bad thing that we used fear and stigma and concealed important facts from people and were non-transparent? And everyone would have agreed that that was a bad thing. But I think when people sit down to plan a public health response, as I mentioned, they're often not considering these really key ethical parameters, even just the potential harms of the intervention and how those would be distributed. That would be a great move forward compared to how we've done this time. And part of that is about understanding the kind of ethical dimensions of what we do as public health practitioners.
Terrific.
Yeah,
Nish,
thanks so
I'll
much,
turn it
Zeb.
over to you. Yeah.
Yeah, it just seems so hard because it's a great point that Michelle brings up, is that if a democracy, I mean, is the political class that is imposing all this stuff in Australia, are they enjoying popular support?
Yeah, I mean, of course they're enjoying popular support. And the reason is because it's quite easy to manipulate human populations by telling them there's a terrifying, dangerous enemy outside the borders, and I'm going to protect you from it by force. And a brief survey of the last 100 or more years of history can show you how easy it is to radically change a democratic society into what resembles a totalitarian state just by striking up that fear about the outside enemy. You can really change norms very, very fast. And importantly, if you divert the whole society's resources to chasing an impossible goal, then you can demand more and more resources get committed to this goal that you can never achieve, and things can get disproportionate and out of control very fast. But people respond to the kind of strong man or strong leader thing of people standing up every day and telling people what to do and what's going to happen. So unfortunately, that has been a successful strategy, but I think in the long term, it's not a good thing for public health. And public health needs to be about engaging with populations, being transparent, treating people with respect and so on, trying to maintain trust, because nobody trusts politicians, for good reason, but people do trust doctors and public health practitioners for the most part. And if we violate that trust, then in the long term, we can't expect people to do, things that might be in the interests of public health.
Do you find where do you find most of your colleagues? Do you find that you stick out like a sore thumb amongst most of your colleagues, or?
Yeah, I mean, I think many people in medicine and public health have really understandably just been overwhelmed by the stress of the pandemic, the huge amount of data coming out. They can't keep up with the information. And they found it easier to just go with the flow and follow the kind of media narrative and not carefully check things for themselves. Not everyone, but a lot of people. And scientists are human beings too. And, human beings respond to fear. And many people have been caught up in this fear. And so I think, certainly I've stood out over the last 18 months, for my views. And that's, can be a risky thing to do. But I think as the harms or the obviousness of the harms of the public health interventions have become increasingly into people's awareness, people are starting to acknowledge that there are trade-offs here. And once you acknowledge that there's a trade-off, then we can have a conversation. And it's really important that people with different views have conversations about this, rather than just saying there's no trade-off, there's only black or white. And I think over time in Australia and elsewhere, I think that opportunity for conversation is opening up as people become aware that there's kind of more than one thing at stake here. And that the goal of public health isn't just about reducing the incidence of one particular respiratory virus, it's about promoting public health in the long term, all things considered, from all potential causes of public health benefits and harms.
Terrific,
well, sir.
Zeb. Thank you very much.
Thank you so much for all this wonderful time that you spent with us. We will, of course, link to your, why don't you just, for the audience, just give us your, the Twitter feed that you'd like to be followed at.
Yeah, so my Twitter feed's ID_ethics, infectious disease ethics, and welcome any feedback.
Fantastic. All right, we'll link to some of your papers as well. Thanks again, Zeb. Great talking to you.
Thanks very much. Likewise.